We're going to start our discussion of some fairly significant classes of recreational drugs, in particular what we call psychostimulants. Now, some of these stimulants, of course, have legitimate uses, but they do tend to be primarily used as recreational drugs or drugs of abuse. We're going to start off with a brief introduction to psychostimulants, talking a bit about their pharmacology, specifically their effects on behavior. Talk about the primary mechanism of action for most psychostimulants, talk about some examples, the physiological responses associated with their use, and some side effects. But we'll start off talking about their effects on behavior. And these drugs have widespread effects on behavior. They do elevate mood, usually through dopaminergic action by blocking the presynaptic transporter or by inducing release of dopamine from the presynaptic neuron. By doing so, also induce euphoria. They increase alertness. Essentially what they do is they engage our fight or flight response, and so they increase our level of alertness much like we would in a high-stress situation or a danger situation. And we'll talk about what that means physiologically here in a bit. They do reduce fatigue, which is, again, one of the reasons they're used so extensively. They're definitely known to increase energy, to decrease appetite, and they do actually improve task performance. And again, this is one of the reasons why they are often used in ways they're probably not supposed to be. Certainly, people in the transportation industry, truckers, oftentimes will use them to improve their driving performance, to keep them alert. The military has long used what they call go pills for pilots to keep them alert during missions. So there is some evidence for that, but their long-term use certainly has some problems. And they certainly can relieve boredom. Again, liking or giving them a high degree of abuse potential. They all have very similar primary mechanisms of action. They all augment synaptic actions of dopamine, which again is a very important neurotransmitter for pleasure and certainly for motor coordination, etc. They're all behaviorally reinforcing. Again, remember the reward pathway in like the nucleus accumbens and some other parts of the prefrontal cortex are all primarily dopaminergic areas. All of them do have medical uses. So for example, a variety of amphetamines are useful for the treatment of attention deficit hyperactivity disorder. Cocaine is used as a topical anesthetic in some situations. They all have significant side effects, toxicities, and certainly patterns of abuse. So they're not without their cost. To give you an idea of what these drugs might be, these are amphetamines, something like dextroamphetamine or D-amphetamine, or just amphetamine, which most of you would know as Adderall. Methylphenidate, which is Ritalin. Ephedrine, which in an herbal form is ephedra or mahlang. Cocaine, which actually oddly is an herbal substance too, and some other that we're not going to spend any time talking about, aside to mention that they are psychostimulants, and those are listed here. They all have a fairly specific physiological response pattern. They induce our fight or flight or fright response, so they increase our attention, our alertness, our vigilance. As a result, they also increase our blood pressure and heart rate. That's to keep in that fight or flight response blood flowing, oxygen available, glucose available. They dilate pupils so we can see better. They alter blood flow to the muscles, which is why people get very strong or can be very strong under these circumstances. Increase oxygen and glucose utilization, and overwhelms our normal alerting or activating response. And in fact, you can get hypervigilance and paranoia because of the induction of that system. Some side effects directly related to those activities are things like anxiety. People get very anxious. They certainly have insomnia. People who abuse methamphetamines can be up for 4, 5, 6, 7, 8, 9, 10 days, which is very, very bad for you. They'll often not eat during that time. People get irritable. They can get intense anxiety and irritability and can exhibit some psychotic behavior. Well, in this lecture, we're going to focus on one particular psychostimulant, which is cocaine. Cocaine has centuries of use behind it, for probably 5,000 years by several civilizations in South America. It's certainly native to those parts of the world: Peru, Bolivia, Ecuador, Colombia, parts of Argentina. It's long been used to reduce hunger and increase energy. In these times, they just simply chewed the coca leaves to get that kind of benefit. We now, of course, have refined and manufactured the products from those leaves. Under Inca rulers, it was sacred, restricted to priests and aristocrats. The Spanish conquerors first tried to ban it, but then realized it would improve the work capacity of the Indians they had just conquered, and so were free to allow their workers to use cocaine. Cocaine in the modern era is very different. There was not much interest in this particular drug until it was isolated in 1855 and named cocaine. Sigmund Freud discovered cocaine and wrote actually a paper called Uber Cocaine, and in this great letter to his wife or girlfriend, I can't remember, he says, in his last serious depression, I took cocaine again, and a small dose lifted me to the heights in a wonderful fashion. I am just now collecting the literature for a song of praise to this magical substance. Freud was a very heavy cocaine user. In fact, he was such a heavy cocaine user that he had almost no sense of smell, which is why in his writings he actually dismisses the sense of smell as being infantile, because he didn't have one. Right around the turn of the 20th century, the drug is used extensively, including by the literati and the upper echelon of the academic world. People like Freud, Robert Louis Stevenson, who wrote The Strange Case of Dr. Jekyll and Mr. Hyde with cocaine use in mind. Sherlock Holmes' keen powers of observation were due to his 7% solution of cocaine. And some of the actions of Sherlock Holmes, for example, his persistent belief that he is uninterruptedly pursued by Professor Moriarty, very much resemble symptoms of cocaine paranoia. Further, the drug was praised by Thomas Edison, the Tsar of Russia, the Prince of Wales, Jules Verne, others, including the Pope at the time. Of course, the original recipe for Coca-Cola had 60 milligrams per 8-ounce preparation. In today's terms, if you have a big gulp, say 32-ounce Coca-Cola, that would be a quarter gram of cocaine, which street value would run you about $30 in one big gulp Coke, and not to mention that's a lot of cocaine. This ought to tell you how much our consumption of Coca-Cola has changed, given that we were drinking it only 8 ounces at a time, and now you can't even find an 8-ounce preparation. U.S. doctors thought it might be an antidote to alcohol and opiate addiction because it produced effects opposite to CNS depression. Of course, turns out it was its own demon. Cocaine was included with the opiates in the Harrison Narcotics Act of 1914 that banned its use and drove it underground until around the 1960s. And by the 1920s, when cocaine had gone underground, it was limited to what we call the cultural avant-garde. Its illegal status made it expensive and glamorous. Cocaine use, of course, decreased and was replaced with amphetamine, and then replaced with cocaine again, and then replaced with amphetamine again, and I don't know where we are now. Cocaine was very popular in the 70s and 80s. The 90s and the early 2000s, amphetamines were certainly more popular. But we do know that its use will generally be determined by price and availability. Methamphetamine is cheaper and more readily available in most places. As we stop methamphetamine use, cocaine might return. And really, the popularity of drugs comes and goes with the times, and certainly some drugs come into fashion, really, as it were. Certainly in the late 90s, early 2000s, ecstasy was a big drug of use and abuse. Cocaine has come and gone, and come again. Who knows where it's at this point. But keep in mind that it is part of its sort of fashion, but also based on its price. And here's what's surprising. We've been engaging in this incredible war on drugs, starting particularly in the 1980s, which has really done nothing but reduce the price of cocaine. So if you were to buy cocaine in today's dollars in 1981, it would be about $600 a gram. if you bought less than 2 grams. Even cocaine, you can get a discount if you buy it in bulk. What you can see is that as of 2003, obviously this is a little old, it was about $100 a gram at that price, which is pretty consistent with what I hear from other folks who know more about this than I do. That's about the same price it would be in today's dollars. If you look at price per region, it turns out Atlanta has the most expensive, or at least did across the time of this chart, and you can again see the prices still declined fairly steadily. The other interesting part of this is the purity of street cocaine is certainly higher than it was. You buy less than 2 grams, you're getting about 70% pure cocaine, compared to in the 1980s it was about 40% pure. So while the war on drug has had some effects, the price and purity of cocaine have made it probably a more attractive drug to use than not. Cocaine has 3 particular actions that are of importance. It's a local anesthetic, which is its primary use in clinical settings. It's also a vasoconstrictor, which has some issues for its use, and is, of course, a powerful psychostimulant. Cocaine comes in a variety of formats. Primarily, it's powder cocaine, which is cocaine hydrochloride, which is a water-soluble and slightly less potent form. Typical dose is 50 to 100 milligrams at a time. People will, of course, do freebase or crack, which can be smoked. It's actually vaporized, which is a much higher dose. You get about 250 milligrams to a gram. It's a lot of cocaine all at once. The routes of administration, or the pharmacokinetics of cocaine, really, a lot of it depends on its route of administration and whether or not you're drinking alcohol with it. And it's important components of cocaine use. It can be absorbed through any tissue, so it doesn't matter if it's snorted, put on skin, swallowed, it'll be absorbed any way it goes. So if it's administered intranasally, which is obviously primary route for most people to use, about 20 to 30% of it is absorbed. Particularly the more it's used, the less that's absorbed. And that's because of vasoconstriction. It actually constricts the blood vessels in the nasal passages, but what happens is the dose continues to be absorbed because it's all still in the sinuses. Plasma levels will peak about 30 to 60 minutes after first dose. The highest prolonged due to continued absorption through those mucous membranes. If it's smoked as base, which is generally mixed with baking soda and water, its onset within seconds, peaks within about 5 minutes, and lasts approximately 30 minutes. So those who smoke cocaine tend to use it a lot more rapidly, and get a lot higher, and has a much greater potential for addiction. Finally, it can be injected and has about a 30 to 60 second onset. So, once cocaine is administered, it is of course distributed throughout the body. It penetrates the brain rapidly. The initial brain concentrations exceed plasma concentrations, so it actually goes to the brain more than it does to peripheral tissues, and it does freely cross the placental barrier. So it's important to keep in mind that this drug will affect the fetus of a pregnant female, because it just freely crosses the blood-brain barrier. There's a whole lore about crack babies in the sort of 1980s and 90s that you might remember. So, cocaine is, of course, metabolized. It has a very short half-life of only about 50 minutes. Rapidly, it's removed from the brain, or from plasma, but a little bit more slowly from the brain. It's detectable in urine for up to 12 hours. Its primary metabolite is detectable for 48 hours. This seems to be longer in chronic users, or chronic daily users, for example. Important to know, though, is that in the presence of alcohol, an active metabolite is created that is only created in the presence of alcohol. So we need to spend just a little bit of time talking about cocaine and alcohol as drugs of co-abuse, as well as why that might be. And it has to do with a substance called cocaethylene. It's an active metabolite of cocaine that is produced in the liver when cocaine and alcohol are used together. It is as active or more active as an indirect dopamine agonist than is cocaine. So what happens is alcohol creates a more potent form of cocaine when it's co-abused, which increases blood cocaine levels by inhibiting metabolism of cocaine. Remember, when you drink alcohol, it slows your liver down. Also results in the production of course, cocaethylene, which increases cocaethylene levels by inhibiting its hepatic metabolism. So it's kind of a snowballing effect here. Cocaethylene is longer lasting. It has about a 2.5-hour half-life and is more toxic than cocaine. And so by combining alcohol with cocaine, it actually boosts its efficacy considerably and makes people much higher and for much longer. Remember, that's about a 5 times, 2.5-hour half-life, sorry. About 3 times as long a half-life. Now, this is one of the reasons why the two are often co-abused together, because you get more bang for your buck from your cocaine if you include alcohol with it. They also tend to offset one another. Alcohol depresses some effects, whereas cocaine increases effects, and so they do offset one another. So let's talk a little bit about the mechanism of action of cocaine. It is a potent local anesthetic. It's still used for this purpose, so someone who might have sinus surgery, for example, might be given some topical cocaine. It is a vasoconstrictor. It strongly restricts blood levels and raises blood pressure, which of course has some problems for health purposes. It takes blood away from peripheral tissues, for example. It's also a powerful psychostimulant with strong reinforcing qualities. Potentiates the actions of dopamine by blocking the dopamine transporter, and does have some effects on serotonin, but it does primarily affect dopamine and the dopamine transporter. So it has very powerful psychostimulant properties. I want to spend a little bit of time talking more about the physiological responses versus the psychological responses to cocaine. So let's take a look at the physiological responses, because these are very important. As I mentioned previously, the psychostimulants tend to affect the sympathetic nervous system, and so all of these things that occur as a result of sympathetic nervous system activity are happening with psychostimulants. Pupils get dilated, bronchi get relaxed, heartbeat accelerates and strengthens, activity in the stomach and intestines are inhibited. This is why people don't eat. And blood vessels of internal organs are constricted, taking that blood out to the peripheral muscles. Now, of course, what this does then is it deprives those internal organs of oxygen and nutrients that they need. So all of these things are happening during that time. So we're activating the sympathetic nervous system, which of course increases our alertness levels, which include motor activity, tachycardia, hypertension, bronchodilation, pupillary dilation, and increased glucose availability. Now, one of the important things to realize about this is that also, because it takes blood away from organs, it has some specific side effects, particular impotence in someone who has used extensively, because the blood's not able to get to those particular parts. And so what we're going to talk about in a minute is there's often an increased desire for sex, but an inability to perform. So that's an important thing to keep in mind. So that psychological response, this is a potent dopamine agonist. It's associated with reward and pleasure. There is a euphoria, giddiness, enhanced self-consciousness, and a forced boastfulness. People feel very sort of indestructible when they're on cocaine. There is an increased desire for sex, although that can be a problem because there is a decreased ability to perform. And importantly, there's a reduced ability to gauge risk. And this becomes very problematic when the last two are combined. Because there's a desire for sex and an inability to gauge risk, then people do engage in risky behavior. This is also true of the methamphetamines, which we'll talk about next time. So some pretty potent physical and psychological responses. Cocaine is one of the very difficult drugs to treat for people who are dependent. Long-term heavy use is certainly associated with serious complications such as cerebrovascular injury. There's a belief that people who use cocaine have microstrokes. Eventually you can get organ failure and cardiovascular risk. At this point, there are no pharmacological treatments. There is a vaccine on the horizon that would make it so that cocaine has no beneficial effects to the person, so they just stop using it. Currently, the basic idea is to support withdrawal. So we want to mitigate withdrawal-induced depression and then engage in cognitive behavioral therapy and social support. All right, we're going to pick up in the next lecture on amphetamines and not